And this meeting is being recorded and is being held at the Discovery Center. So please RSVP for that and let Denise know if you haven't already, if you and plus and or a plus one is coming and what your selections are. So that'll be in person at the Discovery Center, just right off campus on University. And so without further ado, brief introduction to Dr. McAchran. So a pleasure to introduce Dr. McAchran, who's an associate professor of urology in our department. She's also our vice chair for faculty development and wellness. Dr. McAchran trained at the Case Medical Center in Cleveland and finished up her fellowship right down the road, around the corner at the Cleveland Clinic in female pelvic medicine reconstructive surgery. In addition to all her hats that she wears here within UW Health, she's a co-director of the Women's Pelvic Wellness Clinic, and is going to be presenting to us this morning an update about the AUA Interstitial Cystitis and Bladder Pain Syndrome Guidelines. Without further ado, Dr. McAchran.
Thank you. All right. Well, thank you, Dr. Williams, for that introduction. And welcome to Female Urology Grand Rounds. Is this mic picking me up? Okay, thank you very much, Dr. Richards. So I wanted to go over today, excuse me, a little bit of the, because we have brand new AUA guidelines on interstitial cystitis. Dr. Umo looked at those a little bit last week during his indications, but I wanted to go through those a little bit more, in a little more detailed fashion and go over the history that led to this third iteration of those guidelines, and also provide a little bit of a very brief and certainly by no means expert primer on the concept of visceral pain and visceral pain syndromes, which we think a fair bit of IC falls into. I owe a fair bit of, let's see, that's not working. Oh, there we go. Debt to, this is a talk, the beginning of this is a talk that I gave with Dr. Kara King, who was a minimally invasive gynecologist here. She's actually now back at the Cleveland Clinic, that we gave for a number of years to a pain medicine board review course. So that looked at multiple etiologies of chronic pelvic pain. We're going to be looking primarily just at IC bladder pain syndrome. So chronic pelvic pain, really, it's important to think of it not only as a symptom, so pain isn't the symptom of the uterus being injured, but rather as a disease entity into itself. And it's the result of multiple pathophysiologic responses that develop in somatic and visceral structures and the corresponding pathologic excitatory processes in both the central and the peripheral nervous system that lead to this chronic pain process. And for years, we've looked primarily at the end organ. You know, we need to treat the uterus, or we need to treat the bladder, or we need to treat the colon, rather than looking at treating potentially the central nervous system itself to try to alleviate suffering in these folks. Pelvic pain is almost always multifactorial in nature. Part of this is because there is significant overlapping cerebral representation of the somatic and the visceral structures of the pelvis. And there are multiple stakeholders involved in this treatment process. We talked about this a little bit with Dr. Heisler's talk. It's hard to figure out who owns these patients, right? And that can make navigating through the healthcare system very difficult for them as they get palmed around between GI and colorectal surgery, GYN, urology, and pain management, which is a problem I think we still haven't solved and need to solve. In terms of chronic pelvic pain, it's incredibly common. So it's about 25% of women ages 18 to 50 have had chronic pelvic pain that lasted more than 6 months. It's about half of the time a laparoscopy done, that's the reason. And it's the reason for about 12% of hysterectomies in the United States. In the United States, the prevalence of ICBPS is incredibly debated because it's very difficult to define what it is. But it's estimated to be about 2.7% of women and about 1.3% of men. And so I think the long and the short takeaway is it's really common, it's probably undermeasured, and it disproportionately affects women during what should be their most productive years. This is really very brief, and again, by no means expert neuroanatomy and physiology. So if we think about the neurophysiology of acute pain is an essential adaptive response. You feel something burning you and you move your hand away, right? So it alerts you that there's something bad happening and you need to do something about it. Somatic and visceral pain are generated by peripheral nociceptors, which are undifferentiated nerve endings on the peripheral terminals of the primary, afferent, myelinated A delta fibers and the unmyelinated C fibers. And somatic pain typically responds to mechanical, chemical, and thermal stimuli. Somatic pain is transmitted along sensory nerves. Visceral pain, or pain from your abdominal organs, is transmitted along sympathetic fibers. The nociceptive mechanisms of visceral pain are different. Stimuli that would elicit a painful response from somatic structures like cutting or crushing or burning don't elicit that same response necessarily from the viscera. So the sympathetic nerves provide the sensory input from the urologic tract, gastrointestinal tract, and those responses are evoked by distension. I feel like I have to go to the bathroom. I feel like I really, really have to go to the bathroom. Traction, so things getting pulled on, ischemia, and inflammation. And the pelvis has three categories of nociceptors. There are stimulus specific, which we see in the uterus and ureters. Intensity responsive, remember the bladder is getting full and full and fuller. And silent, which those are stimulated by, stimulated by prolonged exposure to noxious stimuli. They get recruited by prolonged exposure to noxious stimuli. And so when we think about pain that isn't doing something useful, that's how I like to think about neuropathic pain, right? Neuropathic, regular pain is telling you you need to move your body away from something or fix something. Neuropathic pain is pain that's not doing something useful. It just hurts. So this is the primary excitatory disorder of the nervous system. It can occur through a variety of mechanisms, like we just went over: trauma, infection, ischemia. It can be idiopathic. Generally, the injured nerve fiber develops ectopic activity and fires spontaneously or fires at a much lower threshold than it used to. So something that didn't used to hurt hurts a lot now. And it can be thought of as inappropriate excitatory activity of these nociceptors. So they're shooting when they're firing when they shouldn't. And it ultimately results in changes in central processing of sensory input. So there's a local problem with it, and there's a central processing problem with it, where that signal gets amplified and distorted. Some of the common causes of neuropathic pain can either be through disease processes, through things that we do to people like surgery or chemotherapy or radiation, through trauma, certainly, through some genetic predisposition. All of those things can lead to neuropathic pain. Another concept to think about is hyperalgesia. What is hyperalgesia? Well, it's pain, right? It hurts more than it should, and it hurts at a lower threshold than it should. So primary hyperalgesia, the nociceptors release excitatory neuropeptides that sensitize those primary afferents at the site of injury. They produce vasodilation and plasma extravasation, or neurogenic inflammation. So they're much more sensitive to anything else that attacks it there or that fires it there. And then secondary hyperalgesia is the central release of excitatory neuropeptides, which then results in the recruitment of those silent nociceptors that we talked about before. So something causes a problem, it gets amplified in the central nervous system, and more nociceptors get recruited, so it feels even more pain. Cyclical process, at least that's how I think about it. Central sensitization is something that even patients sometimes will come in with a diagnosis of central sensitization syndrome now, which previously had been more of just a concept. And there's really a bottom-up and a top-down hypothesis, and probably most of the time it's actually working both ways. So with central sensitization, peripheral sensitization promotes excitability of the spinal cord and the higher center neurons, which leads to an enlarged receptive field and increases the stimulus-evoked responses. So an example of that might be if we repetitively bend the colon at the same amplitude in normal subjects, each time you do it, you'll get higher and higher and higher pain responses. So you're doing the same thing, but it hurts more each time because that is getting amplified as it's going up. And that's a natural thing to happen. Top-down hypothesis is that these initial central changes, so things that are happening like psychological stress or anxiety or fear, which release a bunch of neuropeptides, then increase the central excitability and produce visceral hyperalgesia. So I'm not stressed. And so today my IC isn't bothering me. I had a really stressful situation. And so that same amount of irritation peripherally is bothering me a lot more, or hurts a lot more. It's the top-down hypothesis. When we look at pelvic neuroanatomy, there's the somatic structures, which is the muscle and skin of the abdominal wall and the pelvic floor, the parietal peritoneum, and then the bones. And then the visceral structures are all listed there. Pelvic neuroanatomy, I don't expect you to memorize this, but all converges here. The afferents, the sympathetic, parasympathetic, and somatic all converge which leads to this concept of convergence. So the peripheral specificity from the pelvis can be lost when it arrives at the central nervous system in a process that they call either viscerosomatic or viscero-visceral system interactions. So if you guys can picture that brain homunculus, sensory homunculus, it has the giant head and the huge lips and tongue because that has massive sensory representation in the brain. Pelvis has like this much and the genitalia has like this much. All of it goes there. And so you can't locate where something hurts as much in the pelvis the way you can if you get a pinprick and you can tell that it's this finger versus that finger. It's all sort of mushy, and that leads to that visceral pain of it aches, it's sore, it hurts. And those vague descriptions where you can't really pinpoint exactly what's going on. So there's convergence of both somatic and visceral input onto these same second order neurons. So for instance, we have the bladder sending information here and the colon sending information here. And the colon has something abnormal happening with it, which increases the excitability of this second order spinal neuron, which can make anything coming in from the bladder amplified. So you're having really bad constipation and your bladder pain syndrome is worse that day because of the way the pain is just processed, the sensory input is processed. Normal reactions to urinary tract pain can be vaginal hyperalgesia, urinary urgency, frequency, acute pain, all of those things we see with the UTI. Remember, peritoneal inflammation is reflexive of abdominal garden. And the pathophysiology in chronic pelvic pain allows visceral or somatic pain conditions to enhance or facilitate pain in the other structures that share that same segmental innervation. The neuroinflammatory changes can spread in the dorsal horn, producing both referred pain and referred pathology. And convergence allows both pain and pathology to spread between organ systems. So a negative emotion here, we know alters processing of visceral pain even in healthy controls. We know that the prefrontal and cingulate gyrus are activated during painful rectal distension. We know that there's other brain activity that's enhanced with painful stimuli in dysmenorrhea. So the big concepts I want you to understand is that there's central sensitization, there's convergence of processing, and all of that contributes to pain being the actual pathology rather than maybe always some sort of end organ problem. A little bit more about visceral pain. We talked about this already, but it tends to be poorly localized and refer to somatic structures, right? Everyone knows about ureteral colic. When the stone's up near the kidney, it hurts in its length. When it's in the middle, it hurts at the belly button. It's further down, it hurts in the groin, right? So it tends to produce non-specific regional or whole body motor responses. And it can produce really strong autonomic responses like nausea, vomiting, coldness, flushing. Tends to lead to sensitization of those somatic tissues, and it can produce those strong affective responses. In the pelvis, endometriosis, IBS, painful bladder syndrome, and then chronic prostatitis or chronic pelvic pain syndrome / chronic prostatitis would be the pain syndromes in the pelvis. And just an idea, just to give you a couple of blurbs about these other pain things. So endometriosis we know is associated with central sensitization. Women with laparoscopically confirmed endometriosis were compared to age-matched controls, and they did something painful by injecting hypertonic saline into the back of the hand and the lower back. There are globally lower pain thresholds in women with endometriosis, right? So they feel pain at a lower threshold than normal controls. In IBS, activation of the anterior cingulate cortex has been shown with both exposure and anticipation of the painful stimuli. So if you do something like rectal distension, this triggers a response to modulate that pain way or empty. But it also triggers vigilance and anxiety to then amplify that pain. And that's that pathologic pain response. The differential diagnosis of chronic pelvic pain in women is incredibly broad. I'm not going to go through all of that today, but these are all things that you should be thinking about when that patient comes into your office for that referral. Almost always multifactorial, and generally there's not just one thing that needs to be addressed. I'm going to go over a little bit about assessment, just so you guys have at least maybe a game plan of how you should approach these patients when they come in your office. So a history is really important, focusing particularly on the duration, location, what helps, what doesn't help, and really kind of the historical process that they've had with this. You want to try to characterize that pain. Is it related to activities? Is it related to position changes? And then is it associated, particularly in our clinic, is it associated with the bladder in some way? Is it better when you urinate? Is it worse when you don't? Does it make you feel like you have to urinate? And then a biopsychosocial assessment is, of course, incredibly important as well. Does this patient have social support? Is there a history of any sort of abuse, which certainly increases your risk of having somatic pelvic pain syndrome later in life? Briefly assess their sleep habit and their sexual habits. The chronology is really important. So as a pain syndrome develops, pain can be present over progressively larger areas despite stable pathology. So when did this start? And then how did it become this, and how did it become that? And then a cognitive evaluation. What does the patient think the problem is? What does the family think the patient's problem is with this? These can be really difficult diagnoses to manage because there isn't the typical, here's something wrong, this is how you fix it. Pathway. In terms of physical exam, you want to just look at the patient. Look at how they're seated. Do they have one hip up or one hip down? Do they look uncomfortable in their chair? You want to do a supine exam, which includes gentle palpation for trigger points. You want to examine the abdominal wall, palpate for masses, certainly. A careful but incredibly brief Q-tip examination of the vulva and vestibule can let you know if you're dealing maybe more with vulvodynia or vestibulitis, if they have evoked pain just by touching with a Q-tip at one of those locations. You want to palpate along do a brief vaginal exam. And we'll talk a little bit about the MAP network later, but this is one of the MAP studies that showed if you simply add this very brief vaginal exam looking for trigger points. So this is a map of the vaginal opening. Urethral meatus here, rectum here. And so 11-1 is the urogenital diaphragm, the obturator internus membranes, and the levators. Patients who have ICBPS will have provoked pelvic muscle pain. And that distinguishes them from normal controls. They also looked at whether or not you needed to do a more in-depth nervous examination, like looking for sensory and motor function of the pudendal nerve, and that really doesn't distinguish people, but just this gentle palpation can. And this doesn't add more than about 3 minutes to your total examination. So questions to ask while you're doing that: does this hurt when I press here? Is this the same pain that you were talking to me about when we took your history? And then do you feel that pain anywhere else when I'm pressing? Lab tests are primarily to rule out other things, right? So you want to certainly rule out infectious etiologies. That's what everybody does first. Cytology is certainly reasonable, particularly in a patient who's older or with hematuria. And then there's some endometriosis stuff you can think about. Imaging is primarily to rule out acute visceral pathologies. In terms of imaging, when I have a patient who's coming to me as a subspecialty referral person for their chronic pelvic pain or ICBPS, if they've gotten to me and haven't had some sort of cross-sectional imaging, I will generally do that. I feel like that you need to just make sure that you haven't missed something in the road to getting to you. But that can include a transvaginal ultrasound. That's usually what the gynecologist will start with. I typically will start with a CT urogram. I might employ a pelvic MRI to rule out a urethral diverticulum. And then the RGI folks, if it's more IBS, might use endoanal ultrasound or colonoscopy. So the urologic chronic pelvic pain syndromes, or UCPPS, are broken down sort of by gender, not entirely, but sort of by gender, right? Into chronic prostatitis, or the old name chronic prostatitis, or the old name interstitial cystitis. And we'll talk a little bit about why those names have gone a little bit out of date and why we're trying to replace them with bladder pain syndrome or chronic pelvic pain syndrome in that. But first, I mentioned this last week, and and during Journal Club, I want to mention it again. The MAP Research Network stands for Multidisciplinary Approach to the Study of Chronic Pelvic Pain. It was established in 2008 as a response to, we've tried all of these things to treat the end organ. We've tried all of these therapies to try to make people better with IC by treating the bladder, and they're not all better. Maybe it's because we're not treating the right thing. Maybe it's because we're not approaching the pain syndrome the way we should be. So the MAP Research Network was established by the NADDK to better understand the pathophysiology of urologic chronic pelvic pain syndromes, with that goal specifically of exploring underlying CNS pathophysiology, like pain centralization or augmentation, or augmentation, rather than continue to search for a single unifying end organ problem. And this is their website, and it has a link to all of the studies that they're currently doing, and everything that they've published. And the goals were to advance understanding of both syndrome phenotypes. How can we really better divide this huge bucket of people that we give the diagnosis of ICBPS to? Syndrome etiology, and then the natural history. And then also to better understand the relationships between this and other potentially related chronic pain syndromes. As everyone knows, often these folks have co-diagnoses of endometriosis or IBS or fibromyalgia or chronic fatigue syndrome. So what might be underlying all of those more somatoform disorders? And there's investigators from multiple disciplines. Those are listed on the left. These are all of the sites that are part of the MAP network. There have been about 86, there have been 86 publications since 2014. It slowed down a little bit with COVID, but there have been about 15 or so per year. And they really do span huge, broad ranges of topics. So why is it IC/PBS? And why can't I put in EPIC, painful bladder syndrome, and get that to come up? That I don't know the answer to, but it's irritating. Because it's probably, for a lot of patients, a more accurate description than interstitial cystitis. So why have we worked hard to try to change this name? Because interstitial cystitis implies that there is an interstitium and that it's inflamed in some way. And certainly not all patients have that, et cetera. And this goes back to the original 1990s NIDDK criteria for being included in a study on interstitial cystitis. And I think these are important to review because these have shaped how we think about the disease and how we approach it. So to be included in a study in the 90s on IC, you had to have glomerulations on cystoscopic examination or a classic Conners ulcer. And either pain associated with the bladder, I have pain and I feel like it's my bladder, not I have pain and I feel like it's my bowel, and then urinary urgency. And to evaluate for glomerulations, the bladder had to be distended up to 2 times and then evaluated. The glomerulations had to be diffuse, so if you divide the bladder into quadrants, it had to be in more than 3 quadrants. There had to be at least 10 of them per quadrant, and not along something that you might have damaged or injured with your cystoscope. And the exclusion criteria are huge. So if the patient had a bladder capacity greater than 350 when they were awake, they got booted out. If they had OAB symptoms, they got, or OAB, evidence of OAB on urodynamics, then that couldn't be there. If they didn't have nocturia, they weren't included. And the whole list goes on. So that led to probably us not studying as many people as we needed to figure out how to try to help this, again, broad range of folks. So different groups had different names and definitions. It was hard, there was no gold standard that was agreed upon. So at some point in the early 2000s, the International Continence Society came up with this definition, which is that painful bladder is the complaint of suprapubic pain related to bladder filling, usually accompanied by symptoms such as increased frequency both day and night, in the absence of anything else that you could use to explain that, basically. And soon after that, the first AUA guidelines were published on this in 2011, updated in 2014, and then updated again this year. And I think Dr. Nakata had been talking about Dr. Gant at our last meeting, and he is the first author and has been on these guidelines since the beginning. So these are all based on the original guidelines are based on a literature review from 83 to 2009, 2015 and 14 rather added 31 articles, 2022 added another 53 articles. And you guys know the statement of evidence for guidelines, but I thought it was up there. And our current definition is an unpleasant sensation. So it can be pain, it can be pressure, it can be discomfort, perceived to be related to the urinary bladder and associated with lower urinary symptoms that have lasted at least 6 weeks in the absence of other identifiable causes. And these are the 2014 guidelines, which are fairly similar to the 2011, but they very much codified this or made more prescriptive the first line, second line, third line, fourth line, fifth line treatments, which was great because it gave people a roadmap for how to approach these folks and how to approach treating them, but failed to recognize something that we have known before and are coming to realize again, that there's a difference between folks who have Hunner's ulcers and folks who don't, and that you don't necessarily have to force a patient, and I shouldn't say it like that, but that's how they feel like it, force a patient to go through pelvic floor physical therapy before you offer a medication, right? which is what the stepwise approach can make it feel like to patients. So these are the new guidelines, and the main ways in which they're different have nothing to do with the basic assessment, the clinical management principles, or other things you might consider. But they do definitely divide patients into two separate groups. So these are the folks where you suspect and then confirm Hunner lesions and the pathway for treating them. And then the patients who you probably don't think or you don't see Hunner lesions on and the pathway for treating them. And certainly there can be overlap between those two, but there is coming back to a more distinct idea that these are people who have two different sets of pathologies who probably should be addressed differently. So the main things that have changed, this is less prescriptive and stepwise. It highlights the need for an individual approach with patients. There is that clinical distinction between patients with Hunner ulcers and non-Hunner ulcers. And there is a push in the literature to consider the Hunner ulcer patients really the inflammatory patients, maybe those with people we should be calling IC. And the non-Hunner lesions, the bladder pain syndrome. These are the pain syndrome patients. And it also incorporates the FDA warning on Elmeron, which we'll talk about. What causes IC? Well, nobody knows, and these are the broad categories that we always think about. So infection, really nothing conclusive has been shown. The negative studies outnumber the positive ones. Certainly there are a lot of people who have a long history of urinary tract infections and then develop sterile pyuria and pain. And that seems to be a contributory preamble to developing these diseases. There's a lot of theory about autoimmunity and inflammation because the histologic examination of the bladder reveals pancystitis, perineural inflammatory infiltrates of lymphocytes, and plasma cell activation. Mast cell involvement is proven. You can see increased mast cells at biopsies. Mast cells produce histamine, which causes pain, hyperemia, and fibrosis, all of which are symptoms of IC. Mast cell infiltrates are found in IC, not in other IC patients. And they probably play a central role in the ICBPS, but probably not. It's thought that maybe not a primary pathogenic role. In the last two are both MAP studies. In a transgenic autoimmune cystitis mouse model, where you have a mouse where that has an autoimmune disease, where you create an autoimmune disease of the bladder in the mouse, and then you have some of them who have mast cells and another line that doesn't have mast cells. The non-mast cell mice don't get bladder inflammation, and the mast cell mice do. And in the mast cell mice, if you give them a medication to stabilize, chromalin to stabilize the mast cells, you can reverse that bladder inflammation. So just one of the more interesting studies. And then there is this was just published last year, a possible relationship between high pollen counts and flares in that subpopulation of patients who have both more systemic allergies and IC, which speaks to possibly mast cell involvement as well. And then a whole host of treatments aimed at trying to repair the glycosamine glycine layer of the bladder. That was proposed by Parsons, which is another name in IC you should know, in the 1990s. It's thought that maybe IC is a result of a defect in the urothelium surface layer of the glycosamine glycans, which acts as a protective layer and prevents stuff from getting to those sensory afferents in the suburothelial space. And if that layer is gone, then those sensory afferents are more exposed to pathology, and that pathology can just be things in normal urine than they were in somebody who doesn't have that layer. But this is debatable as well. And then various factors have been looked at to see if there's something in the urine we can look at and say, oh, this is a patient who has IC, with anti-proliferative factor being one of the main ones. But again, not a ton of great data. So the diagnostic algorithm, like I said, not particularly different than in prior iterations. So you should do a history, physical exam, check a post-void residual, certainly, urinalysis, culture, a symptom questionnaire should be included. I admit that I don't always do that, and a pain evaluation. And consider all of these other potential adjunctive diagnostic mechanisms. If they have a UTI, treat it, reassess. The main symptom questionnaire that's been used for years is the Ovirysant symptom questionnaire. So it's a symptom index plus a problem index, and greater than 6 out of a total possible of 36 suggests ICBPS. And a score greater than 12 is pretty strong evidence of that diagnosis. And you can use this to follow patients in terms of response to treatment as well. It doesn't take a ton of time to fill out or include. And then the next step on the new algorithm, again, really puts patients into two different pathways, patients with Hunner's ulcers and patients without Hunter lesions. We're calling them lesions more than ulcers now, without Hunter lesions. In terms of cystoscopic findings, the only consistent finding that can lead to a diagnosis of inflammatory areas or ulcerations are Hunner's ulcers, and that was described in JAMA by Dr. Hunter in 1918. Glomerulations are, in fact, not diagnostic. They can be seen in all kinds of other states. If you stretch the bladder out, you can see glomerulations in a lot of different people. And then there are no agreed upon urodynamic criteria for ICPBAs, but it can provide information about potentially other things that might be going on in the pelvis. Glomerulations look like that. Hunner's ulcers look like this. This was a nice picture showing narrow band imaging, which emphasizes the abnormal capillary structure going towards that lesion. You can see that a little bit better on the right than the left there. And then some pathology slides. So this is a Hunner lesion showing massive plasma cell infiltration and loss of the normal umbrella cells of the bladder. This is a patient who has lesions, but this is a non-lesion biopsy, again, still showing all that inflammation. And then a patient who has ICBPS symptoms, but no Hunner ulcers, and really on biopsy, a normal bladder lining and no inflammatory studies. So it's, again, just trying to bring home that these are probably different pathologic entities, and they present clinically differently as well. So patients who have Hunner's lesions tend to be a bit older at diagnosis, peaking in the early 70s. And patients who have Hunner's lesions tend to have lower voided volumes and a much lower capacity under anesthesia. We talked about one of the things that we do in that group of people is follow their capacity under the anesthesia over time, and it tends to diminish, or it can diminish. Things that you can do to treat Hunner lesions, you can actually resect them like a TURBT. You can fulgurate them either with cautery or laser. Neither has been proven to be one better than the other. There's early studies on triamcinolone injection, and it's actually included in the guidelines, but the data on it's really weak. I personally have not had great success injecting triamcinolone. I think Dr. Gralnick has done some as well. And I know Dr. Bushman did back in the day, and we might ask him to speak about his experience with it later. Most patients will improve. And that's the thing about this. And that's one of the reasons that we're shifting to earlier diagnosis and treatment of patients with Hunner's lesions. So if you see this patient, do the cysto early, because if you find this pathology, this is something that actually is incredibly effective at alleviating pain for patients. Repeat treatment is often needed, but not always. In one study, about 40% of patients didn't need another retreatment within 3 years. So again, consider early cystoscopy. In the old guidelines, the 2011 guidelines, cystoscopy was really down unless you had some other indication to do it, like microscopic hematuria, as a third-line diagnostic therapy. And this is shifting that to think about doing that just a little bit sooner and earlier, particularly in patients who are over 50, because those are the folks who are more likely to have a Hunner lesion. And then these are the people who, again, in the very limited data that we have on it, benefit from potentially oral cyclosporine. So in patients who have Hunner's ulcers, there was an 85% response rate for patients with Hunner's ulcers to oral cyclosporine. But as you know, it's an incredibly toxic drug. So there's nephrotoxicity, hair loss, hypertension, immunosuppression. I've not prescribed this without the help of a rheumatologist. And I've only prescribed it once. For people who are going to respond, they tend to have that effect at about 4 months. But there's a lot of adverse side effects, and it gets discontinued fairly frequently and early. It's important to remember that you should have a basically, common sense approach. No. So start conservatively, try to avoid just a shotgun approach. Stop any treatment that isn't effective. Those are fairly reasonable things to think about. First-line treatments include patient education, self-care and behavior modification, stress management, physical therapy, and then multimodal pain management. So some of the behavior modifications that have been proven to be beneficial include either fluid increase or decrease to either alter the concentration or the volume of urine, application of local heat to the bladder or the perineum, the pubic area, or cold, avoidance of various bladder irritants and foods, meditation and mindfulness to help patients manage and cope with flares, pelvic floor muscle relaxation and bladder urge suppression, with goals of doing either trigger point release if those are found, but not doing Kegels. So it's very important that you have a physical therapist who knows what you're actually trying to treat and that you communicate that. Because if you're the person who treats stress incontinence 90% of the time, and you send your patient to the physical therapist and they treat her for stress incontinence, you're going to make their ICU worse. Bowel regimens, again, constipation can amplify other things happening in the pelvis, so addressing that can be beneficial. And then some of the over-the-counter medications, of which there are myriad, aloe, marshmallow root, various things that patients will come in on. So some of the evidence for behavior modification, this is a 2010 study from Dr. Foster. Patients were randomized to behavioral approaches before starting any sort of med, and those included education on how to manage symptoms, control fluid intake, change their diet, and then bladder training and urge suppression. About 45% of patients had moderate to marked improvement. So just spending a little bit of time doing these things, if you can get buy-in from the patient, can be beneficial. The IC diet. So about 80% of patients report sensitivity to certain food groups. And the most common triggers are caffeine, citrus, spicy foods, carbonated beverages, and artificial sweeteners. And that relationship between dietary intake and symptom changes is also seen in a lot of the other functional somatic syndromes, such as fibromyalgia and IBS. So it's always hard for me to completely understand how something you eat, which gets massively processed before anything ends up in urine, can actually be a trigger, other than maybe caffeine, right, which we know is excitatory and a diuretic. So one of the current theories is that maybe these dietary metabolites act as excitatory neurotransmitters, which then result in that central nervous system sensitization and systemic hypersensitivity. So that's been looked at in fibromyalgia and in some in the rheumatologic literature, which I think is kind of interesting. The other thing that's nice about dietary changes is it does give the patient some agency over addressing this problem. Oral medications that we consider reasonable for this problem include amitriptyline. Amitriptyline is used because of its benefit in neuropathic pain and treating neuropathic pain. It also has some anxiolytic properties. It also has some mild anticholinergic properties, which can help with the OAB symptoms. Cimetidine is a histamine blocker. Hydroxyzine is an antihistamine similar to Benadryl, but also an anxiolytic. And then I'm going to call it Elmeron, but PPS, which is pentosan something sulfate, is thought to help rebuild the glycosaminoglycan layer. And that's actually the only medication that's FDA approved specifically for ICPBS. And the benefit of it is, I wouldn't say marginal, but it helped about 40% of the people in trials. Elmeron and this adverse reaction is certainly something you guys need to know about, one, before you think about prescribing, but also I'm assuming probably for current exams. So pigmentary retinopathy has been noted as an association with women who are, well, with patients, usually women, who are on long-term Elmeron. They generally are older and have taken it for more than 3 years. And the original study noticing this, I think, came out in about 2016, 2017. There have been multiple confirmatory studies. We participated in one here. We don't know why this happens. Apparently, this retinopathy can happen with a number of different drugs that patients take for very long terms, according to the ophthalmologists. But the cumulative dose appears to be a risk factor. And the symptoms patients might present with include difficulty with reading, slow adjustment to going from a lighted room to a dark room, and blurred vision. And in 2020, they changed the labeling for Elmeron, saying that you need to obtain a detailed ophthalmologic history before you start this medication. Patients should have a baseline retinal exam prior to starting therapy, a repeat retinal exam at 6 months after starting therapy, and then regularly, I usually recommend yearly after that for the folks who are taking this. Intravesical treatments are medications directly placed in the bladder. They have a long history as well. They generally fall into either Dmso or these cocktails listed on the table there. And these cocktails generally have some sort of lidocaine, something to buffer the lidocaine, and then maybe something to try to rebuild that glycosaminoglycan layer, like heparin, crushed up Elmeron, chondroitin, and some newer studies looking at hyaluronic acid. I want to talk a little bit about Dmso. I don't know if you guys still get tested on this, but it's something you should know about. We don't use it very often here unless it's a patient who historically has had benefit from it, then I might try it again. It's thought to work by decreasing inflammation, triggering relaxation of the bladder muscles, and influencing inflammatory mast cells. And it's typically instilled once a week for 6 weeks, and then at some pattern thereafter if they have benefit. Dwell time should be less than 20 minutes. This does get absorbed and it hurts, and that's what limits the dwell time. It has a really terrible garlic odor, which also can make it not palatable for a lot of people. And the body of evidence, is grade C. It's not fantastic. So if I'm going to do an intravesical cocktail, I'll tend to do something along this lines. And then procedures. So cystoscopy and hydrodistension we talked about last week. This is something that's done under anesthesia. The hydrodistension, you let fluid run in under gravity with the height of the water anywhere from 60 to 80 centimeters above the level of the pelvis, and hold that for short durations, which is certainly 10 minutes or less, and 5 minutes is probably reasonable. And what can this do? Well, this is diagnostic. So it can rule out other pathology, but also allow you to see and treat a Hunter's lesion, see granulations. It's therapeutic for some patients. It provides long-term symptomatic benefit. If there's lesions there, you can fulgurate them. And again, it gives you some staging of bladder capacity under anesthesia to help differentiate, again, between these folks who have a progressive problem with their reservoir and folks who don't. And then moving on to neuromodulation and Botox. So a trial of neuromodulation may be performed. That's what the guidelines say. It is not FDA approved specifically for this indication, but again, most of these patients have, right, urgency, frequency, pain relieved by voiding. So you can do it for the urgency, frequency part. And that's what you want to, that's what I counsel patients that I expect will and hope will get better, is their urgency, frequency symptoms, because the pain is much less likely to improve. Or if it does improve, it's less likely to improve for the long term. And that's been shown in a number of studies. Botox is an approved treatment for folks who are willing to accept the need for self-catheterization, which a lot of these patients really, really, really won't. They have no interest in that at all. Certainly, we have the normal mechanism of action of Botox, which is to inhibit the detrusor. But also here, where we think it might be helping, is actually by affecting neurotransmitter release at that suburothelial level. So theoretically, if you're injecting Botox for IC, you want to do it just a little more shallowly than you do when you're injecting it for OAB, and maybe actually raise that bleb rather than getting it down into the detrusor muscle. But there's no good studies looking at that. There are multiple randomized controlled studies of Botox versus saline in this population, and the data is difficult. And then finally, like we talked about last week, major surgery. So these are for people, this is what we consider now for people who have failed all other options and have very bladder-centric symptoms. And then for that end-stage small fibrotic bladder that isn't doing what you need a bladder to do, which is hold enough urine to allow you to go a couple of hours between getting to the bathroom, right? The sway here has been, as Dr. Nakata was talking about last week, in the 90s, early 2000s, a lot more cystectomies getting done, both for patients who have these end-stage fibrotic bladders, but also for patients who probably what we think now or think about now is having a more central pain syndrome. And the central pain syndrome patients didn't tend to get better. Pain came back. So there was a big swing back to, okay, we need to stop taking bladders out on these people and tolerating all of those potential, downstream quality of life effects from that, because their pain comes back anyway. And now swinging a little bit back more towards the middle to, this probably is appropriate for a certain group of people. And often those folks are the people who really have the progressive Hunter lesions or inflammation that you can't stop or progresses. That's who I think about heading that direction. I just put this up here because this is another interesting way to think about approaching this population of patients, the input patient phenotype, both for chronic prostatitis and for IC. So if you try to phenotype them as primarily infection related, then you might treat with antimicrobials. If you try to phenotype them as neurologic system, then you're looking at some of those things that treat the nervous system and down the line there. So just overall concluding things, visceral and somatic pain, nociception are different. And visceral pain is affected by central sensitization and convergence, and that's how pain becomes the disease itself. A thorough history and physical exam really are important. It's almost always multifactorial. The Hunter lesion folks probably are the interstitial cystitis folks, and they behave differently and should be thought about and treated differently than the non-Hunter lesion patients. And treatment should be individualized, but also evidence and guidelines based, which is why the guidelines are nice to have. So that's my talk. I'm happy to answer any questions.
Sarah, I have a comment.
Yes, of course.
Back in the day,
Sorry.
just kidding. Actually, that was just a wonderful, wonderful talk. I mean, absolutely wonderful, and I can say that from a unique perspective because I grew up with IC. I was peripherally involved in the first couple of 5-year IC database studies back in the 90s, and that was those were focused on what's wrong with the bladder. And as is true of many transformative research enterprises, the map started by asking a different question. And it was not started out with a central nervous system focus. It was just a multidisciplinary approach to a pain problem. And that's where the name came from. And I was the chair of the External Advisory Committee for the first 10 years. And just an example of how the field was transformed, Henry Lai came up with this idea of just asking people where they felt pain on a regular basis, and created a body map. And it turned out that a large fraction of these patients had pain at multiple sites in the body, and that led to the whole concept of a central pain phenotype. The maps made tremendous advances in understanding these patients, but the answers in terms of what to do are still in evolution. So we're still stuck with a lot of the things we were doing before, but there are some advances. And one thing that I know is in progress is using a very sophisticated electrode array for an intravaginal probe that allows you to not only visualize muscle activity, but also identify specific trigger points, which then might be targeted by something like Botox injection. And it's a very sophisticated approach with computer integration, all kinds of stuff. But it's really sort of cool. So things will be coming along. I have, you talked about triamcinolone. I tried it. I was never overly impressed with it. But cauterization of Hunter's ulcers does work. And I want to finish with just one clinical pearl for the residents, which I think is really important. And that is, you don't have to cystoscope every patient. Okay, a 23-year-old woman who has pelvic pain is I think you can skip the cystoscopy for a while. And I would always keep in mind, given how common sexual assault and abuse is, that there always may be an issue of that in the background that you have to be careful about. But the single pearl is patients with IC rarely have dysuria. They have a lot of pain, but they don't complain of pain with burning with urination as a chronic complaint. And if you encounter that, you should do cystoscopy and a cytology, because I've diagnosed CIS and bladder cancer in a patient who otherwise looked like they had IC. And that's it.
Thank you very much, Wade. Do you know much about the other thing that's coming down the pike potentially is other delivery mechanisms for Botox, like a gel that just is instilled in the bladder and then elutes the Botox over time to be absorbed?
Mm-hmm.
That's been talked about at meetings, but I think is not quite ready for prime time.
Yeah, it's one of the things that people don't know is how Botox works, even for bladder overactivity. While it's been touted as working on the muscle, there's a lot of suspicion that it's actually being transported centrally through axonal transport, and actually working on sensory neurons in the dorsal root ganglia. So that could be a mechanism by which this works too.
Hey, Sarah, it's Sarah. I first wanted to say that is flat out one of the best talks I have ever heard, and you did an amazing job. But my question is about the Hunter's ulcers folks presenting in their 70s or being more suspicious of that. are those typically then people who have not had, pelvic pain or other sorts of pain syndromes before that time? Or is it like a delay in diagnosis? Or is it like they were fine and then suddenly in their 60s this happened? What's the typical presentation of that?
I feel like more often it's more suddenly in their 50s or 60s that happened. It can be a delay in diagnosis because certainly overactive bladder is very common in that population. And so it can be treated as overactive bladder for a while. But remember, I try to think of IC as overactive bladder with pain. Usually overactive bladder patients they aren't highlighting pain as one of their symptoms. So IC falls more into that category. But I think certainly, I think the answer is there. It can be both. But often it's a new problem that they haven't necessarily had before. I felt like for a while I was seeing it in a number of patients who had been treated for breast cancer, but never took that clinical suspicion any further.
I have the IC patients with Hunner's ulcers, at least in my experience, are an interesting subgroup in that it seems to be much more of a very clear-cut, focused pain problem that increases in time as the ulcer recurs, and then after you cauterize them, they go back to a normal life. It's actually quite striking. And then they have an interval of time. It can be 6 months or it could be a year and a half, and then it starts up again.
Dr. Richards.
See if this thing works. Does it work? Okay. Great talk, Sarah. Really enjoyed it. My question's about, I noticed on the guidelines, there's really not, at least maybe I didn't see it, any place for pain medications, like opioids.
Yeah.
And some of these patients probably need chronic pain medication.
Mm-hmm.
I remember when I was a resident, we had Bob Evans, Dr. Evans treated it. He was the candy man. I mean, he was writing out massive amounts of opioids, but they need it. I mean, these patients he saw flying in from all over the country, I think needed it, and he felt comfortable managing their opioid. Is that? And now this was 10 years ago, but is the field shifting away from chronic opioids? Where can you talk a little bit about that?
I mean, I think just as with everything, right? We're getting away from chronic opioids. Pain management is actually in the older guidelines. I think you're right. It may not be highlighted as much here, but at every step you should be making sure pain is addressed, and that's how that's factored in. And I have pain management see a lot of these patients just because they do have a much more multifactorial approach with counseling and coping management skills, et cetera. As with everything, we're trying to get away from opioids. Tramadol, when I was a fellow, tramadol is what we tried to exchange people onto. We aren't going to prescribe you your oxycodone, but you can have tramadol. Certainly Elavil and gabapentin we use fairly frequently for this pain syndrome. And I don't have too many patients on chronic opioids who come to me. I almost never start them. But I think that's probably not the right place either, right? We were over here with prescribing too many, and now we're down here. And at some point, we're going to get to a more reasonable happy middle. Dr. Borza, I'm sure, has comments on that. But and it's time.
Testing this as well. So I wanted to reiterate, an incredible talk. Lots of information in there. Thank you so much for that. So along the lines with so much information, so because it's such a complex topic,
Yeah, so the AUA actually has a lot of nice, they're going to have to update them with the new guidelines, but a lot of nice educational material. And they have a packet specifically that's written for patients on talking about the disease, the different treatment strategies, why we do what we do. And I usually give patients that. We also typically look at the guidelines together. Okay, this is where we are, this is where you are, and this is where we can go. And then the Interstitial Cystitis Association is a good website with reasonable resources. Obviously, sending people to the web for this can be dangerous, but I do think the Interstitial Cystitis Association's information is pretty well vetted. All right, thank you, everybody.
Great talk.